I think we're going to go ahead and get started. Paper number 23, Prompt Intervention in Large Bowel Obstruction Management, a nationwide inpatient analysis, to be presented by Dr. Kwan.
Thank you to the program committee for allowing us to present our work. I also want to acknowledge my research collaborators from the University of South Carolina. So large bowel obstruction is an urgent condition with multiple possible etiologies, benign and malignant, and frequently one of the challenges is the etiology of the obstruction is not known at the time the patient presents. Unlike small bowel obstruction, a large bowel or colonic obstruction is not going to resolve spontaneously. Delays in surgical management can result in bowel ischemia, perforation, sepsis, and even mortality. Yet despite the risks of delay, many patients may not have a prompt intervention, and some of the reasons for that would include the need to resuscitate the patient, the need for gastric decompression prior to general anesthesia, or perhaps the desire for a diagnostic sigmoidoscopy. In addition, the reality is that sometimes operating room resources or the correct surgical expertise is not always immediately available for these patients. We have limited tools to determine the severity of colonic obstruction. This is all entirely based on surgical judgment, and some of the features of assessing the severity of the obstruction are listed below. In addition, there are few published guidelines regarding how quickly one needs to intervene on these patients. With this in mind, we aim to determine whether a prompt intervention, that's surgery or colonic stenting within 1 day of admission, is associated with improved outcomes, and we hypothesize that prompt intervention would be associated with a quicker recovery and decreased mortality. We wanted to look at a variety of surgical practices within the United States, and we turned to the nationwide inpatient sample, which is a population-based data set publicly available from the Agency for Healthcare Research and Quality. We selected our cohort using the following inclusion criteria. We looked at patients who had interventions or hospitalizations rather, between 2010 and 2015. We defined our patients for inclusion based on their ICD-9 diagnosis codes as well as procedure codes. So they had to have a code for bowel obstruction, in addition to a procedure code for a stent, a colorectal resection, or a colostomy. We only looked at patients who were admitted emergently. Our variable of interest was prompt intervention, and that was defined as having the procedure either the day of or the day after hospital admission. In addition, we were quite interested in looking at the etiology of obstruction based on codes that were assigned at the time of hospital discharge, and we used a hierarchical categorization schema that we had previously designed for another study and has been previously published, creating these 4 mutually exclusive categories to determine the etiology of obstruction: colon cancer without metastasis, colon cancer with metastasis, extracolonic malignancy, that would be, for example, in a metastatic ovarian cancer or pancreatic cancer that results in colonic obstruction through extrinsic compression, and then benign etiology for obstruction. The outcomes that we were interested in studying were inpatient mortality, the need for a stoma procedure during their admission, length of stay, and discharge to home. We looked at our outcomes using multivariable logistic regression, and then in the case of length of stay, we used a multivariable linear regression. And we were able to adjust for the variables, confounding variables available through the NIS, age, sex, race, income, comorbidities. We were able to generate a Charlson comorbidity profile. We looked at patient insurance, etiology of obstruction, as I outlined before, as well as some of the hospital characteristics. We identified 31,277 patients who we felt were admitted emergently for large bowel obstruction. 54% were female, 69% were white, 12% black, 12% of other race. And the etiology of obstruction, we found this interesting, was primarily benign obstruction. 65% of those cases had a benign obstruction, whereas only 9% had colon cancer without metastatic disease, 10% had metastatic colon cancer, and 16% of patients were classified as extracolonic malignancy. Among these patients, 42.6% of patients did have a prompt intervention, so either the day of admission or the day after admission. These are the interventions that patients received. Please note that these are not mutually exclusive categories. For example, if you went and had a stent, you could also go on to have a stoma procedure later in the admission. So 5.4% of patients had colon stents placed. 38% of patients required a stoma as their intervention. And then the vast majority of patients had a colon resection, 81%. And most of these were left-sided, as would be expected in patients with a large bowel obstruction. There were almost 20% of patients who didn't have a resection. They got a stoma or a stent alone. Overall, inpatient mortality for the entire sample was 6%. The median length of stay was 10 days, and 69% of patients were discharged home. Did these outcomes correlate with prompt intervention? So looking at our research question, we found that prompt intervention didn't seem to make a difference in stoma creation. So there was no difference whether or not you had your procedure quickly or not. In addition, there was no difference in inpatient mortality. So whether or not you had a prompt intervention didn't seem to impact whether you died during hospitalization in an adjusted analysis. However, we did find that patients who had prompt intervention had a lower length of stay. And in an adjusted analysis, we found that the average length of stay was 2.6 days fewer in patients who had prompt intervention versus those who did not. This would be more than would be expected just by nature of the fact that the patient had their procedure earlier in the admission. We also found that patients who had prompt intervention were more likely to discharge home. We are interested in other risk factors for inpatient mortality in this group of patients who had a large bowel obstruction. Many of our findings here are not entirely unexpected. Patients who were older, specifically older than 55, had a higher risk of inpatient mortality. In addition, the Charlson Index, a higher Charlson score for comorbidity profiles, was associated with higher adjusted risk of inpatient death. We also found it interesting that patients who had colon cancer, metastatic colon cancer, or even just non-metastatic colon cancer, had a lower risk of adjusted inpatient mortality. The flip side of that is patients with benign obstruction seem to have a higher adjusted risk of inpatient mortality. Anyone who had a perforation or peritonitis, either on presentation or during their hospital admission as a complication of the procedure, for example, had quite a high odds of inpatient mortality. There were some hospital characteristics associated with lower inpatient mortality. Specifically, private nonprofit hospitals had a lower risk of inpatient mortality, and urban teaching hospitals compared to rural had a lower adjusted risk of inpatient death. Now turning to our variable of interest, prompt intervention. So we did find that prompt intervention has some benefits. We wanted to know which patients were more likely to have a prompt intervention. And this is an unadjusted table here showing that male patients were more likely to have a prompt intervention. Patients with, who are of Black race were less likely to have prompt intervention. Patients who had higher comorbidities were less likely to have a prompt intervention. In addition, there are a number of other characteristics here associated with prompt intervention. Patients with a higher income level had more quick intervention. In terms of the procedures that were performed, we found that patients who went on to have a stent placed were less likely to have prompt intervention. Patients who had stomas were a little bit less likely to have prompt intervention, although in an adjusted analysis this was not different. Patients who had left-sided colonic resections were more commonly seen in the prompt intervention group. And so when we did a multivariable adjustment to adjust for factors, for example, perhaps Black patients had fewer prompt interventions because they had more comorbidities, we found that actually in an adjusted analysis, a lot of those relationships did persist. So men and male patients and higher income patients were more likely to have a prompt intervention. Black patients were less likely to have a prompt intervention. We also saw that patients who had benign disease seemed to have more likely to have a prompt intervention, and patients who are of higher income also. Some of the hospital characteristics were interesting to note. Patients who were in private nonprofit hospitals were more likely to have the intervention performed more promptly. So in conclusion, slightly less than half of admitted patients undergo intervention within the first 48 hours of admission for large bowel obstruction. Prompt intervention is not protective against in-hospital death, but it does seem to shorten length of stay and slightly increases the chance of discharge to home. We didn't find that it had any protective effect against having a stoma created as part of your management. There's some subgroups who warrant further investigation in association with prompt intervention. These would be female patients, Blacks, and those of lower income. There are some other observations that we found to be of interest. Much of the literature focuses on malignant obstructions, specifically colon cancer-related obstructions. However, a substantial majority of patients here have benign etiologies for their colonic obstruction, and these patients seem to have higher inpatient mortality and perhaps higher acuity. As an unrelated observation, over 50% of patients were managed without a stoma, suggesting that large bowel obstruction potentially could be managed without the need for a stoma, and further research to determine which patients are good candidates for a primary anastomosis, for example, would be important to study. There are a number of limitations using NIS. This is retrospective data with a lot of selection bias, and the codes may not accurately characterize the diagnoses of benign versus malignant. We don't have CT scan reports to understand the nature of the obstruction in any detail, and many features of patient condition on presentation. Other than knowing that they are emergency cases, we don't really know how severe their condition is when they present. And finally, our study does not report on complications or readmissions, which may be other outcomes that would help with this research question. I'd like to thank the Western Surgical Association for selecting our presentation.
This paper will be discussed by Joseph Muldoon.
Thank you very much. Thank you for the opportunity to present here at the Western Surgical, and thank you, Dr. Kwan, for getting me your manuscript quickly. Your study looked at the timing to intervention outcomes for these patients and these obstructed patients. This has not been really studied in depth to this point, and obviously colonic obstruction could be secondary to various causes, as you mentioned, malignant, non-malignant, and can represent complete or partial obstruction. The inability to be sure the degree of obstruction could make it difficult to draw some precise conclusions. You found there was an increased length of stay and with delayed intervention and a higher discharge to skilled nursing facilities. And the question of gender and race is complicated and may be difficult to discern from the data set that you have. It'll be important to drill down on these with further studies on this topic. I have 3 questions. Number 1, did you look at length of stay and outcome differences between right colonic obstructions versus left colonic obstructions after intervention? Number 2, there's a low rate of stoma for colonic obstruction, which is quite low to my eyes. You state that you could not evaluate postoperative complications because of difficulty distinguishing pre- and postoperative causes. Would it be possible to check, though, for SSI and anastomotic leak, as these would likely only be after intervention and may be altered by the timing of intervention and ischemia? Number 3, were you able to assess the Charlson's index and the underlying disease in the patient subgroups who were statistically significant, i.e. the Black, female, and lower income groups? Could this have impacted the timing of intervention? Thank you very much.
Great, thank you very much for your important comments and questions. I'll just go through the questions one by one. So first, right-sided versus left-sided colonic obstruction. This is actually a little bit difficult to parse out in the nationwide inpatient sample because we don't really have accurate codes for right and left in the ICD-9 and ICD-10, either diagnosis or procedure codes. We had basically a soft call for the procedure codes and didn't want to go too far with any conclusions in that regard. However, as I'll get to your next question, which is looking at some of the complications such as SSI and anastomotic leak, I would suggest that this is just a starting point using NIS, but we can go to other data sources to clarify some of those questions. I think that would be really important. So using the NSQIP or NSQIP data set, it's not population-based, but we would be able to determine right versus left in the targeted colectomy sample, and we would be able to determine SSI, other complications, and anastomotic leak. And we actually have begun some analyses and submitted some of those abstracts as well. And then your final question has to do with the comorbidities, or basically the other risks for adverse outcomes in the patients that we found to be treated less promptly, so female patients and Black patients. We did not break down those comorbidities, as you mentioned. We can certainly do that separately. We do depend on the multivariable logistic regression to account for some of those potential confounders.
All right, if there are no further questions, thank you so much. Paper 24, multifilament polyester mesh and self-fixating monofilament polyester mesh offers better short-term clinical outcomes than laminated polypropylene. To be presented by Bo Forrester.
Thank you for the opportunity to present our research. This study was partially supported by grant funding from Medtronic. Inguinal hernia repairs are one of the most common procedures performed worldwide. Operative repair is the standard of treatment for symptomatic hernias. Regardless of operative approach, the use of mesh is recommended in most situations. It was found that 1 hernia recurrence was prevented for every 46 mesh repairs compared with non-mesh repairs. Though post-operative complications can occur due to poor surgical techniques or patient-specific risk factors, the risk of complications may be increased by the use of poorly designed mesh. Due to the existence of many different meshes, mesh selection is an important factor to take into consideration in order to optimize surgical outcomes. The purpose of this study is to determine if differences in short and long-term post-operative outcomes exist between types of meshes following laparoscopic inguinal hernia repair with mesh. Patients were identified from a prospectively maintained quality hernia database containing preoperative, perioperative, and postoperative information of all inguinal hernia repairs performed at a single institution from 2009 to 2021. Patients excluded were those who underwent a concurrent or emergent procedure, patients who did not have a reducible hernia, and patients who did not return a postoperative quality of life survey at any time point. All cases were performed by one of 4 minimally invasive surgeons at North Shore University Health System. Each surgeon had performed more than 100 prior hernia repairs. Repairs were completed using either laparoscopic totally extraperitoneal or laparoscopic transabdominal preperitoneal approach. All patients are asked to follow up at least once in clinic, 2 to 3 weeks postoperatively, and are seen as needed thereafter. 3,476 patients met the inclusion criteria. 3,084 patients had their hernia repaired with multifilament polyester mesh. 231 patients had their hernia repaired with laminated polypropylene mesh, and 161 patients had their hernia repaired with self-fixating multifilament polyester mesh. Age at surgery was significantly higher for multifilament polyester mesh as compared to laminated polypropylene, and significantly higher for self-fixating multifilament polyester mesh compared to laminated polypropylene. 16.5% of patients who had their hernias repaired with laminated polypropylene had a prior ipsilateral inguinal hernia repair, which was significantly higher than the 8.1% of patients who had their repair with self-fixating multifilament polyester mesh. Additionally, recurrent hernias were repaired with laminated polypropylene in a significantly higher number of cases compared to both multifilament polyester mesh and self-fixating multifilament polyester mesh. Median days of narcotic use was significantly higher for patients who had their hernias repaired with laminated polypropylene as compared to those who had their repairs with multifilament polyester mesh or self-fixating multifilament polyester mesh. Median return to activities of daily living was significantly longer for patients who had their repairs with laminated polypropylene as compared to multifilament polyester mesh and self-fixating multifilament polyester mesh. As well, median return to activities of daily living was significantly longer for patients who had their hernias repaired with multifilament polyester mesh as compared to those who had their hernias repaired with self-fixating multifilament polyester mesh. A significantly higher percentage of patients who had their hernias repaired with laminated polypropylene were admitted within 30 days of the operation as compared to those who had their hernias repaired with multifilament polyester mesh. Patients who had their hernias repaired with laminated polypropylene had a significantly higher percentage of hematoma development as compared to those who had their repairs with multifilament polyester mesh or self-fixating multifilament polyester mesh. Finally, patients who had their hernias repaired with laminated polypropylene had a significantly higher number of recurrences as compared to patients who had their hernias repaired with multifilament polyester mesh or self-fixating multifilament polyester mesh. On multivariable analysis, laminated polypropylene was associated with postoperative narcotic usage greater than 3 days and a return to activities of daily living longer than 7 days. Overall, use of laminated polypropylene in laparoscopic repairs of inguinal hernias was associated with longer narcotic use and a longer return to activities of daily living. Thank you.
This paper will be discussed by Dr. Shirin Tofai.
Thank you, Bo, for presenting your data and experience with 3 types of mesh and laparoscopic TEP inguinal hernia repairs. There's quite a bit to analyze in your database of over 3,400 patients operated on by 4 surgeons. My first question is related to the underlying choice of hernia meshes in the laparoscopic inguinal hernia repairs: the laminated polypropylene, the flat braided polyester, and the self-fixating monofilament polyester. In many institutions, the choice of hernia mesh are a mixture of surgeon preference and the availability of the biomaterial at your hospital based on contracts. Though flat and self-fixating or gripped polyester meshes are considered standard mesh options for extraperitoneal inguinal hernia repairs, laminated mesh is not. It is intended for intraperitoneal placement and not for extraperitoneal use. In fact, a recent study presented at the Academic Surgical Congress this year by the Henneford Group at the Carolinas Medical Center support that concern that many of us have in using this type of mesh extraperitoneally, and that is that the adhesion barrier may incite a delay in adhesion and therefore in healing with a higher risk of seroma recurrence and infection. So this was actually part of the experience we had with the Physio Mesh product, which was a laminated on both sides, and this mesh was thereby voluntarily removed from the market by Ethicon. So my first question is, what is the decision behind the choice of laminated polypropylene mesh in your TEP inguinal hernia repairs? And what is the weight of this mesh as compared to the others? Is it ultra lightweight, lightweight, midweight, or heavyweight? There's quite a bit of data analyzed in your study, and I congratulate you for tackling all of that. I have questions related to your analysis of this data. Some of the significance you found on linear analysis fell out in the multivariable logistic regression. For example, you showed the use of laminated polypropylene resulted in significantly more discomfort and pain compared to the others, but specifically compared to the multifilament polyester and not to the self-fixating monofilament polyester. And the significance was measured at a p-value of 0.049 with a confidence interval limits at 0.99 and 0.98. Based on these results, do you feel that your conclusion of superiority of one mesh type versus the other may be a bit too strong? With these very narrow statistics, one could conjecture that a slight variance in data collection from your very talented research associates could have resulted in a different result and thus a different conclusion. My last set of questions are related to the title of your presentation and your conclusions. They imply that polyester mesh is superior to polypropylene mesh. Are you indeed implying superiority of one mesh type versus the other, or more likely about the inferiority of laminated meshes in general, or a particular weight of mesh in general? And are you limiting your conclusions to laparoscopic TEP or all mesh use in all hernia repairs? Thank you. I congratulate you for exposing differences in practices and outcomes the more transparent we are and the more we know about hernia repair, the better we can adapt our practices in an effort to improve patient care, because it's never just a hernia repair. I enjoyed reading your manuscript, and I'm privileged to be his discussant.
Thank you, as always, Dr. Tofi, for your insightful comments. I also want to thank the Western Surgical for the opportunity to present our data here, and it's been a wonderful meeting, so I appreciate that. And I also want to thank Bo. Bo is a pre-med student who just presented, and he's been running our hernia database, which has over 8,000 patients in it right now, with a partner for the last 4 years. But he does spectacular work. 8,000 patients. He's sending out quality of life surveys, putting those into a database, scanning the charts, looking for recurrences, follow-ups on CT scans and exams through our electronic medical records. So he does a lot of work, and he's presenting that to us every week at our research meetings. So thank you, Bo, and you did a great job presenting. In terms of your first question, I agree 100% with your statement about the laminated mesh. We tried to avoid using brand names here, but that is PhysioMesh. That laminated mesh is PhysioMesh. It's not any other mesh. And the purpose of this study, as you know, I'm sure your clinic appointments are now probably twice as long, with that doubling in time due to a conversation about mesh with patients. After you diagnose a hernia in a patient nowadays, and then you talk about options, including repair, the next question from that patient is always, are you going to use mesh? I don't want mesh. You ask why you don't want, why don't you want mesh? Well, because on TV it's bad, it's dangerous, blah, blah, blah. So we really now are looking through our database to figure out, and to also prove to patients that mesh is safe. As a matter of fact, not only is it safe, you want mesh, because without mesh, you'll probably feel worse. Not only will you have a higher likelihood for recurrence, but you'll actually have worse outcomes. And what we wanted to do here is just look at the 3 most common mesh that we've been, that we've used. That PhysioMesh experience was, 10 years ago or so, before it was pulled off the market. We were one of the first to start using it. And what was attractive, and in retrospect, it seems so stupid that we would think that laminated mesh would incorporate and have tissue ingrowth, soon and work well. But again, it's all retrospective. At the time, what was very attractive about the mesh, and the reason that certain surgeons use that mesh, was because of its ease of use. When you have a laminated mesh, whether it's polypropylene or any material, that mesh is very easy to use. You put it in, it opens up immediately, you place it, you don't have to, in contrast to self-fixating mesh, which if you've ever used ProGrip mesh, very difficult to move around because it sticks to everything it comes in contact with. So I think the reason that the surgeons, our surgeons, used the PhysioMesh was mostly the ease of use, with the promise from the company that it was going to be better than what's out there. We actually learned, through that PhysioMesh experience, how to introduce new mesh to patients. We have never since introduced a new mesh without a protocol, without an IRB protocol. If there's no data on a new mesh, we will put a study together, whether single or multi-center, and that way at least you sit down with the patient, you have an IRB in front of you, and you say to the patient, this is a new mesh, it's supposed to be better, but it could be worse. If you elect to use it, if you elect to join our study, then we may use it if it's a randomized trial. But if you don't want it, I understand. We'll use what we've been using for the last 5 to 10 years. And that's the only way. So that's what happened when ProGrip came out, actually. There was no data behind ProGrip. And so rather than just taking it and using it, which I would think a lot of people probably in this audience do it that way, including us in the past, rather than doing that, we actually put together a randomized trial. So that ProGrip that you see in there was part of a randomized trial that we did with about 400 patients, 200 in the Priatex group, 200 in the ProGrip group. And interestingly, we found that, and those results are published, but interestingly, we found that there was no change in recurrence rates or quality of life, but it's 5 times more expensive. So, for the most part, we haven't really adopted ProGrip as a common mesh in our series. So that's kind of our rationale between using a different mesh. And then, as you know, with hospitals these days and contracting We don't have 10 different mesh on the shelf anymore. We really try to come to an agreement amongst the surgeons as to which mesh we all agree to use, and we try to find as much data behind it before we decide on that mesh. But that's the rationale behind that. Now, in terms of question number 2, I totally agree that we have to interpret these results with caution, just mostly because of the small effect size in our multivariable analysis. But having said that, you know, you're talking about almost 3,500 patients, and we still believe these results are significant. And then as for your last question, I actually think you're right, and it helps, and I think we may edit our paper. I think that we're not trying to say that polyester is better than polypropylene. I think what we're just showing here, the title is what it is, which is we had better results, you know, quality of life-wise, even recurrence and univariate analysis with polyester mesh, but probably doesn't mean that polyester is better than polypropylene. It just means that this bilaminated mesh is not as good. So you're absolutely right, and I appreciate you pointing that out, and I think we need to probably have a discussion about that in the discussion section of the paper, saying we're not saying polypropylene is bad, because that would have bad ramifications as well. Polypropylene, I think, is an absolutely adequate material to use for hernia repairs. So excellent, insightful questions, as always, Dr. Toffi, and I appreciate it.
Thank you, Dr. Ujiki. Paper 25, Variation in Hospital Costs and One-Year Episodes of Care Following Hiatal Hernia Repair, to be presented by Dr. Kolstretha.
Good morning. My name is Sujay Kolstretha. I'm a general surgery resident at Loyola University Medical Center in Maywood, Illinois. Thank you to the Western Surgical Association for the privilege of the podium to present our work. We have nothing to disclose. There's been growing interest in utilization of alternative payment models to combat the rising costs of healthcare. Rather than using a fee-for-service model in which providers bill individually for specific services rendered, there's been consideration of episodic or bundled payments, in which a group of providers or facilities receive a lump payment for a several-month episode of care. Proponents of these efforts have suggested that these lump payments improve provider collaboration and improve quality of care across the treatment pathway. Given this, the Center for Medicare Services has investigated use of these episodic payments in bariatric and oncologic procedures, but has noted significant variation in costs of care between different facilities, making identification of a single episodic payment difficult. Thus far, alternative payment models have focused largely on shorter-term, 30 to 90-day episodes of care for oncologic resections. There's been limited data on non-oncologic episodes of care, particularly for routine general surgery procedures. The effect of using longer durations of postoperative follow-up that could reveal delayed complications presenting after 90 days is unknown, and the causes of this significant variation in costs of care is unclear between facilities. To that end, we assess the variation in hospital costs for hiatal hernia repair. We aggregate the one-year costs of care related to the repair for hiatal hernia repairs by facility. Using this information, we identify the least expensive and most expensive facilities and determine the sources of cost variation in our analysis for hiatal hernia repair. We use the Healthcare Cost and Utilization Project's Florida State Inpatient Database, a data set that allows for tracking of inpatient encounters longitudinally, as well as the State Ambulatory Surgery Services Database, which allows for tracking of outpatient and ambulatory surgery encounters. We identified patients undergoing a transabdominal hiatal hernia repair using ICD codes between 2011 and 2018 in the state of Florida. We followed patients for 1 year postoperatively to identify all relevant episodes of care, both inpatient and outpatient, within the first postoperative year. We examined short and long-term patient care outcomes, index hospitalization costs, and postoperative aggregated charges for the first postoperative year, and utilized reliability and case mix adjustments to identify and classify hospitals into cost quintiles from least to most expensive. Reliability adjustment is a method of accounting for low surgical volume hospitals by shrinking their costs to the global mean. In doing so, this method provides a more accurate representation of hospital costs by minimizing the variation and noise related to low surgical volume. Between 2011 and 2018, a total of 8,848 patients underwent a hiatal hernia repair in the state of Florida, at 158 facilities. Using reliability-adjusted costs, we organized these facilities into 5 hospital quintiles, with the first quintile representing the least expensive hospitals and the 5th the most expensive hospitals. Here we have the number of patients treated at these facilities. Hospitals in the least expensive cost quintile treated the highest number of patients, a total of 3,331 patients, or 37.6% of our cohort. Conversely, hospitals in the most expensive quintile treated the fewest number of patients, a total of 744, representing 8.4% of our population. Here we have demographics and comorbidity information for patients treated by hospital quintile. Patients being treated at hospitals in the least expensive quintile were more often younger, of Caucasian race, and had higher rates of privately insured patients as compared with patients in the most expensive quintile. These patients additionally had a lower comorbidity burden as measured by Alex-Hauser scores. With respect to facility characteristics, there were no significant differences in either for-profit status or urban setting by hospital cost quintile. There was a higher rate of hospitals in the most expensive quintile with fewer than 100 beds. Additionally, there was significant variation in annual case volume by hospital cost quintile, with hospitals in the least expensive quintile performing a median annual case volume of 9 procedures as compared with 3 for hospitals in the most expensive cost quintile. We found that surgical outcomes also varied with increasing cost quintile. Hospitals in the least expensive quintile had a shorter length of stay, a higher proportion of patients discharged to home, and fewer repeat episodes of care within the first postoperative year. They did demonstrate higher rates of postoperative endoscopy, but lower rates of reoperation. With respect to costs of care, we present reliability and case-adjusted figures for both index hospitalization costs and one-year aggregate charges. Index hospitalization costs are generated from HCUP with use of the provided cost-to-charge ratio by the data administrators for the state inpatient database. With respect to costs, adjustments for reliability and case mix demonstrate an $8,992 difference in hospital costs for the index hospitalization between hospitals in the first and 5th quintiles, a difference of 89%. We examined one-year aggregate charges for the first postoperative year as there are no conversions to costs for the ambulatory surgery services database. Examining these charges, hospitals in the least expensive quintile generated approximately $50,000 less in hospital charges than those in the most expensive cost quintile. The graph to the right depicts one-year aggregate charges broken down into index hospitalization and post-index hospitalization charges. Index hospitalization charges are indicated by the red, and the gold bars indicate post-index hospitalization charges. As you can see, much of the variation in costs is decided at the index hospitalization, with the pattern in variation changing very little with the addition of post-index hospitalization charges. Overall, we found a nearly 2-fold difference in the cost of a hiatal hernia repair at Florida hospitals over this time period, despite adjustments for both reliability and case mix, indicating a significant amount of cost variation for a hiatal hernia repair. The majority of this variation occurred at the index hospitalization, with the addition of charges related to post-index hospitalization encounters affecting the cost variation pattern minimally. Hospitals in the most expensive cost quintile generally perform fewer annual hiatal hernia repairs with a prolonged length of stay and a lower proportion discharged to home as compared with hospitals in the least expensive cost quintile. Bundling payments for a hiatal hernia repair has the capacity to decrease healthcare costs by targeting the variation in postoperative outcomes and hospital costs as we have demonstrated here in this study. This study has several limitations. As an observational study, there's inherent potential for confounding and selection bias. However, we attempted to minimize this as best as possible by using reliability and case mix adjusted analyses. Additionally, the HCUP data set lacks granular components of costs, as well as costs associated with post-acute care, such as those associated with skilled nursing facilities or rehabilitation services, which would undoubtedly inform a one-year global cost discussion and could help identify sources of variation. Lastly, the study was performed in a single state, in Florida, which subjects our results to a regional bias. Despite this, we conclude that there was a significant amount of variation in costs of care associated with hiatal hernia repair, primarily generated during the index hospitalization. Cost savings could be afforded to payers, providers, and patients with the implementation of bundled and standardized payments for hiatal hernia repair. Thank you.
This paper will be discussed by Ninh Nguyen.
Yes, this is a really nice study examining the accurate cost of care for 1 year for a common general surgical operation, that's a hiatal hernia repair. So I have 2 questions and 1 comment. The first question being that costs can be divided into direct costs, meaning supplies, OR costs, etc., and then indirect costs, which is just the cost of leaving the lights on and running a facility. So you didn't really look and examine, I'm assuming you didn't examine between the two, but if I was an administrator, one of the ways we can cut costs of a hiatal hernia repair is a mandate no more mesh, right? Because mesh costs a lot of money. But then RCT demonstrated there is a reduction in early recurrence associated with mesh. So in my clinical practices, we utilize mesh selectively depending on the size of the hiatal hernia. So my question to you is that you could implicate bundle payment, but I think you got to be careful for what you ask for, because there could be consequence. The first thing is that, one, we're probably not going to let the resident do the case anymore because we want to be quick and get out of the OR. That's one, and you're a resident. And then number 2 is that we will start eliminating some of the necessity and taking it away from the surgeon choice with regarding to, utilization of expensive items such as mesh. So that's the first comment. First question. The second question is related to the indirect costs. I mean, that's huge, and that's so variable. I would say if I do the same exact operation at UCI and go to another facility right around the corner, the cost is literally could be half. Outpatient facility tends to have much lesser cost because they have a lower cost structure and they have a low overhead. But when you talk about an academic center, the cost is sky high. Why? Because we utilize the clinical enterprise to subsidize our other mission like education, research, etc. So cost structure between facility really varies a lot. So my question is that, did you look at that? I mean, are these primarily, the higher costs are related to more academic centers? And my last comment is really related to the HICCUP database. We utilize this database a lot, and we believe that the most important variable for the HICCUP database is mortality as an outcome measure. But complication and cost, I would say, is less reliable. So the issue I have with the costs in this database is that it's utilizing charge multiplied by cost to charge ratio, which is very inaccurate. As you know, charges is so variable among different institutions, and that's exactly what the data kind of shows. So if you want to start a bundle payment, you better know exact costs, because otherwise you're going to lose your shirt. So one of the initiatives is by the American College of Surgeons that is actually looking at the true cost. So they partner with the Harvard Business School looking at time-derived costing, so TDABC. So this is an initiative that we want to look at the true cost rather than the cost associated with these type of HICCUP database. So maybe you can comment on that. But otherwise, thank you for the comment. I mean, thank you for the ability to comment in your paper.
Dr. Marshall Baker has joined us on Zoom to close. Thank you, Dr. Baker.
Good morning, everybody. Can you hear me? Good. We wanted to thank the Western for allowing us to present this data. And again, I thank you all for your deference in allowing me to make these comments remotely. I wish I could be there with you. Dr. Nguyen raises some great questions and comments about the analysis. As is often the case with these big data projects, we trade granularity for statistical power, and it limits our ability to kind of answer some of his questions. We can't, I think, know with the limits of HCUP whether these are direct costs or indirect costs, and we can't do things ideally the way we would want to in terms of adjusting for case complexity and issues like that would really help make this analysis sort of more robust. But what I think we can do is make the comment that there is significant variability when we do the risk adjusting that we can as best we can, that there is significant variability in the costs of care, and that there are probably institutional reasons for this, meaning that some institutions are actually doing a very good job taking care of these patients, and others honestly are doing less of a good job or taking care of too few of them to be efficient at it. And I think we make an argument that regionalization might be a good thing to pursue in cases like this. And I think make an argument that having some kind of a cost limitation or a bundled payment method might help drive a better practice. There's no question complicated, and it's probably beyond the scope of our ability right now, given our limits to understand cost perfectly. Dr. Nguyen is absolutely right. There's no such thing as a activity-based accounting in healthcare at this point. When I did my MBA at Kellogg 20 years ago, we didn't have activity-based accounting. Then everybody's talking about it then too. We still don't have it. The college is trying to help drive progress in that direction. That would certainly make this type of analysis better and make it easier for us to be more fair about doing things like enacting bundled payments. But I think without question, there is significant variability. Without question, there are opportunities to shrink costs and provide good care for patients. And I think that this type of analysis points us in that direction. So again, we thank the Western for the opportunity to present this data. We'd be happy to answer any further questions that you have.
Question from Dr. Ujiki.
Yeah, Mike Ujiki, North Shore. Congratulations, Marshall. Well presented. I think yet another study that shows that if you are a high volume center, you tend to be more efficient and cheaper. I have two questions. The first one is in regards to the postoperative endoscopy. Is there a time limit on that? Is that within a year of the surgery, within a few months? I think that might be a quality indicator, actually. And in your study, you had the cheaper institutions were more likely to do a post-op endoscopy, which the cheaper institutions also happen to be the higher quality institutions, less complications. Mm-hmm. And so they were more likely probably to get patients back who needed surveillance endoscopies for Barrett's esophagus or for bad LA grade D esophagitis that needed to be looked at post-op. So is that endoscopy within a year, 2, 3, 5, or just any time after the surgery? That's number one. And then number two, Marshall, have you finally seen the light, and are you leaving hepatobiliary surgery for foregut?
Oh, Mike, I appreciate your questions, and I've been trying to stay out of your territory forever. So the answer to that question is no, but I definitely am interested in as you know, health economics and general surgery in general. So this was a project that Sujay and I kind of embarked on a couple of years ago, and it just kind of crossed common grounds for both of us in terms of our interest. To answer your question about the endoscopy, this is for a year's worth of time after the index operation, and I think a lot of the statistical work that went into this was to use HCUP SID and HCUP ambulatory surgery data sets and link them so that we could follow the patients for a year following their operation. And the initial thought was that we might see some differences in an outcome that would be best measured over the course of the year. Are they getting repeat dilations because of quality issues, or are they getting repeat endoscopies because the care that they're getting in the OR is not what you would want it to be? And I think as it turns out, Sujay pointed out that most of the variation in costs and probably care are happening in the hospital, but there are variations that happen outside. And you're probably right that the post-op endoscopy or the follow-up endoscopies are a quality indicator that track with the high-quality centers. So.
Okay, thank you, Dr. Baker and Dr. Kostresa. Paper 26, Challenging Surgical Dogma, Are Routine Postoperative Day 1 Labs Necessary After Bariatric Operations? To be presented by Omer Sharik.
Good morning, everyone, and thank you for the opportunity to present this work. My name is Omer Sharik, and I'm a general surgery resident at Mayo Clinic. I'm here on behalf of Nicholas McKenna. We have no disclosures. So the Choosing Wisely campaign has called into question many routine medical practices that have now been shown to have limited to no benefit for patients, and in some cases may even cause harm. In conjunction with SAGES, Choosing Wisely have released guidelines that limit the prescription of opioids postoperatively. Similarly, guidelines that reduce the number of preoperative labs that are requested have also been issued. However, the surgical tradition of checking postoperative day 1 labs after abdominal operations remains largely unchallenged. Now, our group has previously shown that post-op day 1 labs after colon and rectal surgery are very rarely abnormal and are very infrequently acted upon. However, whether this data also applies to bariatric procedures is unknown. Furthermore, an increasing number of bariatric surgeries are now being performed on an outpatient basis. Therefore, the question of whether post-op day 1 labs are warranted is possibly more pertinent than ever. With this in mind, the aims of our study were twofold. Firstly, we wanted to determine how often post-op day 1 labs after elective bariatric surgery were clinically warranted, i.e. were abnormal. Secondly, we wanted to determine whether these labs represent value-added care given their associated costs. And we set out to address this by carrying out a retrospective cohort study of adult patients who underwent elective primary and revisional bariatric surgery over a 9-year period. At our institution, patients are placed on a standardized postoperative pathway, and a CBC and complete metabolic profile are not compulsory but are often ordered on postoperative day 1. We included patients that had at least a post-op day 1 hemoglobin, potassium, creatinine, or glucose measured before 8 a.m. on the following day after surgery. And the reason that we picked these labs in particular was because we anticipated that if abnormal, they would be most likely to lead to some sort of intervention. Now, to avoid a situation in which a patient would have to undergo postoperative day 1 checks for a given lab, we employed lab-specific exclusion criteria. So for hemoglobin, this was a preoperative hemoglobin of less than 8. For the potassium and creatinine analyses, this was a preoperative diagnosis of chronic kidney disease. And for the glucose analysis, this was a preoperative diagnosis of diabetes. We defined an abnormal post-op day 1 hemoglobin as a level of less than 8 in concordance with transfusion guidelines. We also considered a drop of greater than 3 to be an abnormal drop. And we were interested in looking at active interventions in response to these abnormal values. So we looked at the incidence of blood transfusion. Moving on to the comprehensive metabolic profile, we defined hypokalemia as less than 3.5 and mild and severe hyperkalemia as greater than 5.5 and 6 respectively. And in response to hypokalemia, we were looking for potassium repletion. In response to hyperkalemia, we were looking at any medications that were given to reduce the potassium. We defined acute kidney injury as an absolute creatinine increase of 0.3 compared to baseline, or a 1.5 times increase. And we looked at the incidence of hypoglycemia as a glucose level of less than 70 milligrams per deciliter, or 180 milligrams per, or greater than 180 milligrams per deciliter. And we looked at the proportion of patients that got dextrose to correct hypoglycemia or insulin to correct hyperglycemia. Now, our institutional policy unfortunately prohibits us from publicly sharing cost data for inpatients and for labs. So in order to estimate these costs, we looked at the costs derived from the 2020 Medicare Part B outpatient fee schedule, with the acknowledgement that these costs will vary widely depending on hospital status and payer status. So this flow diagram provides an overview of our study cohort. So there were 2,090 patients in our cohort, and of these, 2,087 were eligible for our hemoglobin analysis, 1,987 were eligible for the potassium and creatinine analyses, and 892 were eligible for the glucose analysis. Looking at the overall cohort's characteristics, the majority of patients were female, and the most common procedure performed was a Roux-en-Y gastric bypass, followed by a sleeve gastrectomy, and the overwhelming majority of procedures were performed laparoscopically. Moving on to the hemoglobin analysis, so 96% of patients in our cohorts had a post-op day 1 hemoglobin that was checked. And strikingly, only 0.2%, so 4 patients, had a hemoglobin level on post-op day 1 that was less than 8. And none of these patients required a blood transfusion. Similarly, the proportion of patients with a hemoglobin drop of greater than 3 grams per deciliter on post-op day 1 was also low at 3%. We performed a univariate analysis to try and predict which factors may be associated with a post-op hemoglobin drop of greater than 3. And we found that female sex, open operations, and longer operations were significantly associated with this. We then looked at creatinine, and we found similarly that a very small proportion of patients had evidence of stage 1 or stage 2 acute kidney injury on post-operative day 1. And again, a univariate analysis showed that there were certain risk factors such as male sex and urine outputs immediately after the operation that were associated with this. Looking at the potassium analysis, we found that a similarly very low proportion of patients had potassium abnormalities on post-op day 1, and only 1.7% of all patients that had a post-op day 1 potassium required some sort of treatment to correct this. On a univariate analysis of factors associated with an abnormal potassium, we found that older age, male sex once again, and urine output on the lower side was associated with this. A very large proportion of our patients had a preoperative diagnosis of diabetes, which left us with 563 patients that had a post-op day 1 glucose checked. And again, only 2% of these patients had an abnormal glucose level, with no patients having hypoglycemia. And of these patients with an elevated glucose, none required insulin. So in summary of all the post-operative day 1 lab values, which amounted to over 5,000, only 1.5% were abnormal, and only 0.4% were actually actively acted upon. So I think it's important to consider this in the context of cost. So as a rough estimate of $22.15 per set of labs, if there were 2,090 operations performed at our institution over the study time period, that's looking at an excess cost of $46,000. And if you put that into the context of nationwide, where it was estimated in 2018 that 250,000 bariatric procedures were performed, you're looking in excess of $5.5 million spent on post-op day 1 labs, which could really be avoided. There are some obvious limitations to our study, and as mentioned by others, this is a retrospective study that has limitations inherent with that design. We weren't able to look at vital signs that may potentially have predicted post-operative day 1 abnormal labs. And as I mentioned earlier, we didn't look at institutional cost data. We also didn't have a control group of patients that did not have serum labs obtained that we could compare to. So with these limitations in mind, I just want to leave you with some discussion points. Based on this study, we would argue that a post-op day 1 hemoglobin should be selectively ordered in patients undergoing elective bariatric surgery for open operations and where the operative time is longer than expected, or when intraoperative blood loss is more than expected. And this is nothing new, this is mainly clinical common sense. Similarly, a post-op day 1 potassium and creatinine should probably be selectively ordered for patients that have evidence of oliguria immediately post-op, or those that have relevant comorbidities. And with the very low frequency of abnormal glucose parameters, we argue that these checks are unnecessary as part of a comprehensive metabolic profile in non-diabetic patients. And by taking this targeted approach on board, you might be able to avoid unnecessary serum lab draws and increase the possibility that actually drawing a lab would lead to a change in management. So in conclusion, labs that are routinely checked after bariatric surgery are rarely abnormal, and even when they are abnormal, very rarely require some intervention. And this probably constitutes the definition of non-value added care in this context. So the take-home message from this study is that post-op day 1 labs after bariatric surgery should probably be replaced by labs that are ordered based on comorbidities that a patient may have, or some of the clinical criteria that I outlined in the previous slide. And I'm happy to take any questions. Thank you.
Our discussant, Neil Ellis from Valley Health, is unable to be here, and so I have his discussion to read. Surgical tradition and dogma are a comfort for surgeons because it requires very little thought. As a proud graduate of the University of Alabama, Birmingham, our chairman, Dr. John Kirkland, advocated simple, standard operating procedures, SOPs, or now called clinical pathways, as a way to keep things from slipping through the cracks. However, these SOPs were the opinion of the attending and were never subjected to scientific scrutiny. This can no longer be the case with the increasing need for the efficient use of finite resources, and I wish to commend the authors for their effort. However, to play the devil's advocate, I do have some questions for the authors. During the time frame of this study, bariatric procedures evolved from primarily adjustable gastric bands and Roux-Y gastric bypass to sleeve gastrectomy. You did perform a subset analysis comparing open to laparoscopic procedures. Did you also perform a subset analysis to determine if routine laboratory evaluation was more useful following one specific procedure compared to the others? Were primary procedures compared to revisional procedures? Number 2, you focused on hemoglobin, potassium, creatinine, and glucose on post-op day 1. What about the other components of the routine post-op day 1 labs? Specifically, white blood cell count and serum bicarbonate, with a reported 1 to 3% incidence of early anastomotic leak after bariatric procedures. The presence of a persistent tachycardia plus a leukocytosis or metabolic acidosis on post-op day 1 is very concerning and will usually result in further evaluation at our institution and hopefully prevent delays in an intervention for an anastomotic leak. I guess my question is, how many total patients were further evaluated or an intervention performed because of routine post-op day 1 labs? You looked at the cost of these laboratory tests, but these costs have to be compared to the costs incurred with a delay in the diagnosis of a post-surgical complication, as mentioned in our prior question. What was the incidence and time to diagnosis of complications in this cohort? What were the increased costs related to these complications? A $22.15 per patient investment to improve outcomes and potentially avoid some of the costs of these complications may be a wise investment. I would appreciate the authors' comments. Again, I wish to commend the authors for a very good study and thank them for the opportunity to review their manuscript.
So thank you very much, Dr. Ellis, for passing over your comments. I think all the points that you've raised are very excellent ones. Some of the comments, some of the questions that you raised came up in the discussion or in the talk. However, I'll just touch on them again. So the reason that we picked the labs that we picked, so the hemoglobin, potassium, creatinine, glucose, is we felt that those were labs that, if abnormal, would lead to a prompt intervention. That being said, the point you raise about bicarbonate, white blood cell count, and tachycardia as a vital sign being a reason for alarm, we completely agree with, and would be worth looking at. We just didn't focus on those particular labs in this study. In terms of your question about the proportion of patients that had an abnormal lab that actually led to an intervention, so it was less than 2%. So again, we're showing that in addition to these labs not being abnormal a lot of the time, when they are abnormal, often what will happen is that lab will be repeated and there won't be any active intervention that's required. Unfortunately, we didn't look at the timing to complications. I think that was one of the questions that you asked about. We didn't look at the specific timing of that, but I agree that would be very interesting to look at. And referring to your question about a subset analysis of the specific types of procedures, that's a very excellent question, and it's not something that we have analyzed yet, but would be very interesting to do potentially at this point for the manuscript.
I have one question for you. What was the incidence of overall complications in this population?
It's very low, so it's about 3%.
Okay. Thank you very much.
Thank you.
Paper 27, serum bilirubin at the time of cholecystostomy tube predicts the need for subsequent cholecystectomy. To be presented by our winner of closest to the pin from the golf tournament, Dr. Adam Berenson.
All right, well, first I would like to thank the Western Surgical Association for the opportunity to present our work this morning, and also for mentioning the golf success, which was only on some holes. We have no disclosures to report. The Tokyo guidelines are well known within general surgery. They stratify patients into 3 categories based upon the severity of acute cholecystitis, with subsequent management recommendations for each. Grade 1 patients tend to be healthy with mild inflammation. Grade 2 patients display a more severe presentation with elevated white count, a palpable mass, length of symptoms, or marked local inflammation. Finally, grade 3 patients display evidence of end organ dysfunction. Cholecystectomy is the preferred treatment for acute cholecystitis. However, in patients with baseline medical comorbidities or grade 3 acute cholecystitis, a percutaneous cholecystostomy tube provides an effective, less invasive option. The tube manages cystic duct outflow obstruction, but really serves as a temporizing measure. While cholecystectomy is the non-controversial, ideal approach to manage patients with acute cholecystitis that can tolerate surgery, less is known about the fate of patients managed by tube drainage. We performed this study to determine the outcomes of patients that received tube drainage. We analyzed our data to determine if we could predict the patients that would eventually have cholecystectomy and to determine the fate of patients following tube placement. We identified all patients at our institution with acute cholecystitis requiring a percutaneous cholecystostomy tube. We excluded patients with insufficient data or those undergoing another major operation at the time of cholecystectomy. Our study period was from January 1st, 2012 to July 31st, 2020. All patients were managed by our acute care surgery service and were treated according to the attending's discretion. Our faculty favor cholecystectomy when feasible. Therefore, tube drainage was reserved for patients with contraindications to surgery or severe sepsis. We divided patients into 3 categories. Group 1 underwent ventral cholecystectomy. Group 2 had the tube removed without further intervention, and Group 3 had the tube left in place. We documented the variables listed on the slide. Additionally, we collected data on cholecystectomy when performed. For patients that recovered from their acute illness that presented to our surgery clinic, some proceeded to cholecystectomy, while the vast majority were evaluated to determine chole tube and cystic duct patency. 3 techniques were utilized: contrast cholangiography, a clamp trial, which was used when the tube volume output was low, and the final technique was tube removal as part of cholecystectomy, or when output was negligible for several days in the absence of right upper quadrant abdominal pain. Included here are images of cholangiograms for 2 of our patients. On the left side of the screen, you can see the tube coming in to the gallbladder with a patent cystic duct and contrast filling within the duodenum. On the right side, once again, the tube coming in, and this patient displays obstruction of the cystic duct and many stones present within the gallbladder. Statistical analysis was performed for continuous measures such as total bilirubin with an ANOVA or regression model, followed by a post-hoc comparison when the overall group effect was statistically significant. Similarly, for categorical measures such as race, we initially performed chi-squared or Fisher's exact test, followed by a post-hoc comparison. 209 patients underwent tube placement for acute cholecystitis. 17 were excluded due to insufficient data, and 13 were excluded due to the timing of cholecystectomy in conjunction with another major operation. 179 patients were included for full analysis. We've included a flow chart demonstrating the various routes for our patients. On the right side of the screen, you can see the 30 patients that were excluded. 66 patients never had tube removal. 113 patients received further surgical management. We performed a clamp trial in 17 patients, with 5 proceeding to cholecystectomy and 12 receiving simple tube removal. We had a cholangiogram in 55 patients, with 17 proceeding to cholecystectomy. Finally, we had 41 patients managed solely based upon their output or symptoms. 21 of these proceeded to cholecystectomy. When comparing the patients that had the tube left in place, they are more likely to have an ASA-4 classification and had higher rates of mortality. We found a mortality rate of 97% in patients in the tube left in place group versus 35 and 40% for the cholecystectomy and tube removal groups respectively. When comparing the cholecystectomy patients with the tube removal patients, the cholecystectomy group had a higher serum total bilirubin at the time of diagnosis. The bilirubin was on average 3.4 in the cholecystectomy group versus 1.8 in the tube removal group. The remaining clinical characteristics were not statistically significant between the three groups. For patients that underwent cholecystectomy, 53.5% were completed laparoscopically, with 27.9% beginning lap with conversion to open, and 18.6% of patients were approached open to begin with. We further broke down the means for assessing distal biliary flow and the decision to proceed to cholecystectomy versus tube removal. A total of 17 patients underwent a clamp trial. 11 patients were asymptomatic and had the tube removed and did well. 6 patients had abdominal pain during the clamp trial, of which 5 went on to cholecystectomy, while 1 remained medically unfit and was managed with tube replacements as needed. 55 patients underwent cholangiogram. In 6 patients, the tube had migrated outside of the biliary system. 5 of these patients had the tube removed and 1 elected for cholecystectomy. In 11 patients, cystic duct obstruction was noted. 7 went on to cholecystectomy. 4 patients, due to medical comorbidities, had their tubes initially left in situ. However, on later evaluation, had cystic duct patency with tube removal. Of the 38 patients with cystic duct patency on cholangiography, 29 had tube removal without issue afterward. 7 patients had recurrent symptoms and proceeded to cholecystectomy, while 2 elected to have cholecystectomy. 41 patients had neither a clamp trial nor a cholangiogram, and rather were managed based upon tube output or symptoms. 11 patients had an elective cholecystectomy. An additional 10 had cholecystectomy due to additional symptoms. 1 patient had recurrent symptoms, however remained unfit for surgery, and the tube was kept in situ. At subsequent follow-up, the tube was able to be removed without recurrent symptoms. 19 patients were asymptomatic and tolerated tube removal. Patients who receive percutaneous cholecystostomy tubes are in poor medical condition. 97% of patients with the tube left in place died during our study period. And of the patients that presented for follow-up and underwent either cholecystectomy or tube removal, more than 1/3 of the patients died during our study period. Serum total bilirubin at the time of diagnosis was a predictor of more significant biliary obstruction. We hypothesized the elevated bilirubin reflects a more severe form of cholecystitis and a lower likelihood of reestablishing cystic duct patency. For patients that recover and present to our surgery clinic, cholecystectomy is favored for the small cohort that regain fitness for surgery. If the patient remains unfit for surgery, an assessment of distal biliary flow is important to guide ongoing tube management. Thank you.
This paper will be discussed by Dr. Rifat Latifi.
Thank you very much, and congratulations first on an awesome presentation, and in the golf too. You should have come and played with a winning team last night. So they would have been much better. I thank the Western Surgical for the privilege of discussing this paper and the authors for sending me the paper way in advance. The study of serum bilirubin at the time of cholecystectomy to predict the need for subsequent cholecystectomy is a retrospective study that in my calculation about 113 patients, and concluded that that bilirubin can predict the need for future cholecystectomy. I have a couple of comments, and I'll give you 3 questions at the end. While I enjoyed reading the manuscript, there should have been a consideration for adjustment of other variables and confounders. From my read of this manuscript, it is perhaps safe to conclude that bilirubin level at the time of diagnosis at best is associated with higher rate of cholecystectomy. Another issue with this paper is the study design. As you know, and as demonstrated in this study, retrospective studies notoriously have a lot of missing information, which makes it really difficult to come up with a strong conclusion. It seems to me that since PCT is a very common procedure, this opens up a new opportunity for us collectively to design an either a prospective cohort study or even multi-center randomized clinical trial to be led and organized by WSA. The questions that need to be answered are very simple. Who should undergo PCT? Should we clamp or do the tube cholangiogram? And when and how, if at all, we should perform cholecystectomy? Personally, I think we're doing way too many of these, and I never know if we are draining a dead gallbladder because you had 100% mortality of those who had the tube was left in. How do we know that we actually drained the disease without and having a dead gallbladder inside? We have seen those quite a bit. So questions. Would you consider using other statistical analysis methods such as building a multivariable logistic regression model with backward stepwise elimination as a method to obtain more realistic results? In this model, the outcome-dependent variables would be cholecystectomy versus no cholecystectomy. The main independent variables would be the type of intervention, clamp trial versus cholangiogram versus neither. Question, maybe I missed, but I wonder, was there a difference in the outcomes among these patients treated with a PTC based on the presence of stones versus no stones in the final outcome? I seem to remember a Japanese study that demonstrated that if there were no stones, the majority of patients treated with PTC did not need cholecystectomy at all. And finally, number 3, I was perplexed with the surgeons, each of them using their own technique to deal with these patients. Will this study change your collective management of acute cholecystitis in the future, as it appears to be many ways to deal with AC? I congratulate the authors and particularly you with a great presentation. Thank you.
This paper will be closed by Dr. George Furman.
Thank you, Dr. Latifi, for your comments, and thank you for claiming that we sent you the manuscript far in advance of the meeting, which you and I both know is not true. And also, congratulations to Dr. Brassel on her recent election to the presidency. Regarding your question about the study design, I totally agree. It's flawed. This whole thing was born out of a discussion, a heated discussion at an M&M conference about complications that ensued after a PTC catheter. We learned a lot from doing this study, but we know there's a lot more juice to squeeze out of this, and I think we're really just getting started. Your question regarding stones, I think we elected to approach this based on looking at cystic duct patency. I suspect that the patients that regain patency are the patients who probably don't have a stone burden. I think if you get bad acute cholecystitis and you've got stones, you're probably never going to reestablish your patency. We had a couple of patients who had a cholangiogram, showed patency, who then developed symptoms, and that may very well be due to stones, and that's something that we could probably tease out in our further efforts. I think the take-home message from this study is that these patients are incredibly sick. I have to tell you, when we first got started getting the data back and the Excel spreadsheets were getting filled, I had no idea that the mortality was this high. It reflects, although yes, it involves 5 different surgeons, I have the great fortune to be the only old one among the group, and so a lot of the policy my policy and my prejudice gets reflected in so many of these types of decisions. And I think I've influenced my young partners that everybody gets their gallbladder out unless there's a really, really good reason not to take their gallbladder out. And these patients who are, 3+ sick or, grade 3 Tokyo guideline cholecystitis are really, really poor surgical candidates, and they don't do well, which I think gets to your final question. We put tubes in when there's no other choice, and once we have a tube in, we really, really want to try to reserve cholecystectomy for the rare cohort that fully recovers.
Dr. Ujiki and then Dr. Shearer.
Yeah, Dr. Ujiki, North Shore, Mike Ujiki, North Shore. I was just curious if you are familiar with the PEBBLE technique, the percutaneous endoscopic biliary lithectomy. The very new choledocoscopes, which have a lot of the spyglass in particular that has a lot of range of motion, and it's very, very small with digital imaging. We've actually been going in on these patients who are not surgical candidates but do not want to live the rest of their life with a tube in. We've actually been just going through their cholecystostomy tract and removing all the stones, and it requires zero anesthesia. There's no pain, so they can lay there. We do it in the operating room, but it could be really anywhere. Some IR folks are doing it. What are your thoughts on that? I'm sure it's not a well, performed, frequently performed procedure right now, but I'm actually really impressed at how well it works. What are your thoughts on that?
Our IR guys are phenomenal, but our advanced endoscopists are using all the spyglass technology to do all sorts of things I never would have thought possible. And I think that's a good point, and it's something that we ought to be thinking about and talking about for those patients who come back to clinic, are functional in the sense that they're not laying in bed all the time, but you really know that their ejection fraction is still 10%. And I'm not talking about their gallbladder, I'm talking about their heart.
Hey, Doug Shore, St. Louis. I was just a little curious. I think I saw you 40% mortality in those that were operated on for a gallbladder, and I just thought that itself was pretty high. Are there people who shouldn't be operating in that number? And I'm not trying to say shy away. There may be some in the 100% mortality too, people that we didn't control the sepsis, as already was mentioned. But 40% seems still pretty high for a gallbladder operation, which is quasi-elective.
Yeah, and well, to clarify, the 40% is over the life of the study, which the median follow-up is about 3 years. So these patients, but I will tell you that the 90-day mortality, I think, was 14%. So nothing to be proud of. But again, I think it just reflects the patient population we're operating on. All right.
Okay, thank you, Dr. Furman. This concludes this session, and I invite you all to stay for the last session. And we will start in 5,